Now we are talking about a very exciting topic, diverticulitis, but we're going to cover the whole gastrointestinal tract. We're going to cover some important mimics, so we'll have a lot of fun and excitement. So we're starting at the top, working our way, duodenum, jejunum, ileum. We'll actually talk about appendiceal diverticulitis, and then we'll work our way around the colon. We're going to cover some wonderful flavors featuring uncomplicated, perforated, fistulizing, and the formation of liver abscesses. And when we talk about fistulizing diverticulitis, we're going to cover a variety of fistulizing forms, including bladder, vagina, ovaries, and bowel. And we're also going to talk about some important mimics. But let's start with small bowel diverticulitis. So one of the things when you encounter small bowel diverticula, and maybe you've never encountered small bowel diverticulitis, it's very exciting because they can be large and quite dramatic, and they can look a lot like an abscess. So that's a big difference than their colonic counterparts, especially in the sigmoid colon, which tend to be relatively small. Probably your major differential item will be ulcer. You might even be tempted to say differential includes ulcer versus diverticulitis, but I'm going to show you why that is not necessary. And actually, well, I guess your differential could be abscess, ulcer, or diverticulitis, but let me try to convince you why you should lean into diverticulitis. And keeping in mind for ulcers, that perforated ulcers do not typically form a walled-off collection like we're going to see for diverticula. We had all those cases earlier where we saw free air, and then for that non-perforated one, it was relatively small. So you'll see these are a different flavor. When we get into the mimics, we're going to talk about epiploic appendicitis, omental infarcts, foreign body perforation, and ischemic colitis. We are starting with our first case of duodenal diverticulitis, and this one is not an eye test. There it is in all of its glory. So kind of this big, inflammatory-looking collection containing mottled air right along the pancreaticoduodenal groove. Take a look at a coronal. And these are not particularly common, but I think if you kind of rack your brain a little bit, this is a common location to find duodenal diverticula within this location. And a couple other observations. It's got a well-defined wall. It's definitely inflammatory, and it has that kind of mottled-looking material in it. So when you're making this diagnosis, if you do benefit from prior studies, this is the old study for that same patient, that can be a really helpful confirmatory piece of information for you. So there it is, right? The non-inflamed diverticulum filling with oral contrast. The one in the previous case obviously was obstructed and acutely inflamed. And that patient can be managed with antibiotics. So really important to tie that all together for the patient. Doesn't need an endoscopy, doesn't need any other further intervention, and certainly doesn't need a drain. This is a case of jejunal diverticulitis, and here's our presentation case. So we scroll down, we encounter this inflammatory-looking structure, and Corona will provide a little bit more insight into kind of the orientation with the bowel. So let's take a look at that. Okay, here we are. So we don't have to go too far on coronal. Here's that jejunal loop, this thickened inflammatory rind, and then this really interesting central structure that actually looks like it's resulting in that obstruction of that neck communicating with the jejunum. So this was appropriately diagnosed as jejunal diverticulitis. One of the other things I want to point out in these cases when you're thinking that it might be small bowel diverticulitis is look for other diverticula to help you kind of realize, this is a small bowel diverticular former. So you're going to find along the mesenteric border these little tiny outpouchings that kind of resemble their colonic counterparts. See if we can find any more. Here's like another one here. So just kind of look for other diverticula to help you realize this is a small bowel diverticular former. So what happened 5 days later? This patient got antibiotics, but came back with persistent abdominal pain, nausea, and vomiting. A little bit of a different picture this time though, right? So that diverticula has largely decompressed, and the inflammation surrounding it is getting better, probably what you'd expect in 5 days, but now there's an obstruction. And where's that oval structure that we saw before in the lumen? It's not really there anymore. So scrolling down and following the dilated small bowel into the right lower quadrant, we find that oval structure, and maybe kind of blending in with the enteric contents, but this is the cause of obstruction, and so that migrated and caused small bowel obstruction. And what did they find in the OR? They found this really interesting obstructing enterolith, almost like a gallstone ileus type equivalent case where you had migration of a stone causing a more distal small bowel obstruction. So certainly an interesting clinical story for this patient. So I was going to mention why we need to be careful about calling these abscesses. And here's our cautionary tale. So this is another case of jejunal diverticulitis, really kind of getting a sense of its characteristic appearance, right? That thickened wall, surrounding inflammation, that mottled contents. If the patient has oral contrast, because the neck is obstructed, you wouldn't expect to see oral contrast. And then here we have that thin channel of communication here. And so, yeah, kind of going back to make the point before I transition. So if you're going to call this an abscess, then you need to know what the next step is going to be. This patient is, or even put in the differential that it could be an abscess, that they're going to call interventional radiology and potentially have a drain put in. So being aware of this diagnosis and being confident making the diagnosis, it's very important because this patient was unfortunately diagnosed or thought to have a potential abscess. And here we have a percutaneous drain placed with that thin channel of communication here with the jejunum here. And eventually the drain was removed, so without any further complication, but totally an unnecessary procedure in the setting of diverticulitis. All right, so here we have a mystery case here. So let's see another variation just to be keeping in mind here. So as we scroll down, we'll encounter this inflammatory collection that is getting really close to the anterior abdominal wall, actually causing that asymmetric thickening of the rectus abdominis. And the coronal image here. I'm gonna have to work for it and scroll all the way over here. Okay, here's that coronal image. So interesting case, right? So there's this inflammatory collection, thickening of the rectus abdominis, and then this linear kind of dense defect along the posterior margin. So any ideas of what this could be? Fishbone. There are things that go perforate in the night. We have fish bones, chicken bones, grill brush bristles. So these are things to be cautious of and be aware of the various appearances. So fishbone, grill brush bristles are relatively thin. Often chicken bones, you can kind of hallucinate a little bit of a kind of a medullary cavity or a little bit of differential appearances that are a little bit thicker. I think these are particularly terrifying because these are commonly used and should all be thrown away immediately. Let's take a look at just how challenging these cases can be without necessarily being aware of the diagnosis. So this patient came in, we do our diligence, and we find this thickened segment of colon here. And along the posterior margin is actually that grill brush bristle that they removed. I have in the pathology picture in the upper corner. And it almost looks like a hyperdense vessel, but obviously the vessels aren't really quite that bright, but really could be easy to overlook, called diverticulitis, or maybe even like an intramural abscess. Oh, here we go. And then scrolling along that posterior margin, you get a sense that you really have to have a high awareness of the potential of a dense foreign body like this. But this was that metallic bristle. All right, as we work our way down, rounding out diverticular disease, and we're getting to the right lower quadrant. Here is what looks like a perforated appendix, right? So it's kind of coming almost from, looks like it could be coming from the cecal base. We're coming up, and there's even a couple liths here and some inflammation surrounding it. But as we scroll down just a little bit more, actually up a little bit more, excuse me, we find the appendix coming off normal, separate from that structure. So normal appendix is going to be the key to making this diagnosis, as it can often mimic appendicitis. And then also, if you're carefully evaluating where that structure is arising from, you can appreciate that it's arising from an ileal loop in the right lower quadrant, not the cecal base. And then there's that normal appendix right there, rewarding us for our diligence, Meckel diverticulitis, with a perforation of the tip. So when you're dealing with large bowel diverticulitis, now we're going to kind of move on from small bowel, and we're going to start with the appendix and work our way down to sigmoid colon. So we're going to keep our eyes open for early signs of perforation or other complications, and we're not going to let ourselves get fooled by mimics. And again, those mimics include epiploic appendigitis, omental infarct, foreign body perforation, and ischemic colitis. Okay, appendiceal diverticulitis. Maybe you've never heard of this one, and this is not one that I've commonly encountered, probably only just 1 or 2 cases of it, but it's really an interesting diagnosis to make. So let's kind of orient ourselves. So here's the cecum with oral contrast, terminal ileum coming in, and then there's actually a couple of cecal diverticula. I'm just going to scroll down a little bit, and there's the appendix. So appendix is right here. And then there is that diverticulum. Let me just kind of convince you that this is real. There it is, okay? There's that inflamed diverticulum. Let me find that on coronal for you. And management on these are not as straightforward as the colonic counterparts, but this patient did have a good response to antibiotic therapy, but eventually went for appendectomy just because it's a kind of an unusual case, unusual presentation. There it is, appendiceal diverticulitis. So it can occur. And actually, interestingly, as we scroll back on this one, there's a second diverticulum right there. So even other diverticula on this appendix. Cecal diverticulitis, anecdotally, at least in my experience, you tend to see them in younger patients. Can be probably most cases I've seen have been like younger female patients, although you can see them in a variety. These get a little bit bigger than the more distal colonic patients, but just want you to be aware of that appearance. And this big diverticulum, you're going to be looking carefully at the appendix, making sure that you are excluding acute appendicitis, but then otherwise just able to confidently make that diagnosis, cecal diverticulitis. A couple mimics, especially when you're dealing with the right colon, to be aware of. So first mimic, I'm just going to scroll down here. Okay, so we're seeing thickening. Is it inflammatory? Well, that's kind of like intermediate soft tissue appearance, isn't it? So you do have to have your threshold for when you're saying, okay, I'm dealing with an acute inflammatory pathology, or am I potentially dealing with a neoplasm? So this is a cecal adenocarcinoma, but there's really kind of pronounced thickening there. And of course, like I mentioned earlier, you're going to look for secondary signs that support malignancy. And there are big, bulky, abnormal lymph nodes. So not only do we have big lymph nodes, but we have abnormal enhancing lymph nodes with heterogeneous kind of low attenuation centers. So just keeping in mind, now we've crossed over that threshold from low attenuation inflammation into soft tissue density and ileocolic adenopathy, really raising our concern of cecal adenocarcinoma. Okay, well, I promised to show along the whole GI tract, so we're going to keep it going here. We got transverse colon. So here there's like an early perforation with more robust surrounding inflammation than we typically experience. Seeing diverticulitis in the transverse colon is not a particularly common diagnosis to make, but certainly an important one, and highlights the importance of a complete search pattern where you're running the entire bowel in a systematic fashion. When we get to the descending colon, this is probably where we're encountering our most common diverticula or cases of diverticulitis in our practice. Sometimes it can be a little hard when there's such robust inflammation to find the exact site. And you might start thinking to yourself, am I dealing with a infectious inflammatory colitis? Could this be an ischemic colitis? So just carefully look and evaluate that location for the culprit diverticulum. And in this case, it's this posterior projecting diverticulum where that kind of epicenter of inflammation is. All right, beware of mimics. Let's take a look at this case here. So here we have that impressive colonic inflammation, but as we scroll through, it's really involving a longer segment of the colon. And as we scroll all the way down, maybe it looks like it's tapering off by the sigmoid colon. So, when you're dealing with a case of colitis, defining the segments is going to really inform your differential. So as we get to that we're at the splenic flexure here, but kind of distal transverse, it starts to look normal, and then we remember, oh yeah, it looked kind of normal in the sigmoid colon, right? So the distribution that we're dealing with here is descending colon, and look at that impressive submucosal edema, mucosal enhancement, and that serosal thickening and enhancement. But we're really along the vascular distribution here. We're along the distribution of the IMA. This is a case of non-occlusive ischemic colitis. And this is a very, very typical place. In fact, this is one of our most common diagnoses that we make out of our emergency department for all comers for abdominal pain. The patient will present with bright red blood per rectum, and you're going to often see involvement in an IMA distribution, but it's non-occlusive ischemic colitis. So I do make a point of adding that because I think it's a point of confusion for a lot of the providers. And they think, oh, the next step for this patient is going to be to get an angiogram. But this is due to transient hypoperfusion. It can be for a variety of causes. We can see it in young patients, maybe who are dehydrated or participating in an athletic event. and we'll see it in older patients related to medications or transient hypotension. So be aware of this diagnosis and be able to make it confidently can provide a lot of help and direction to these patients. And I have found that checking the note for bright red blood for rectum is a nice confirmatory clinical finding to seal the deal. Now we're touching on uncomplicated diverticulitis of the sigmoid colon, which we'll breeze through because I think we've all seen this plenty of times in our practices here, but we have that nice fecalith, that nice rind of inflammation, and that surrounding inflammation. And this video doesn't want to play. Let me go back and see if that one will play here. Okay, here we go. One of the things with your search pattern, so now we are going back to the basics a bit, but when you're dealing with a left lower quadrant pain patient and there's a concern of diverticulitis or you have a white count is unexplained, especially in an at-risk age group, maybe you'll find as you scroll through the axials, there can be some projections of the diverticula that are easy to scroll by. And so I would encourage you to consider adding, running the colon and your coronal search pattern, because what you're going to find as you scroll through these cases is that you might just catch that diverticulum, that inflamed diverticulum and that colonic inflammation to a much more convincing extent, especially in more subtle cases. So just consider adding a coronal run of the colon, and you'll catch a couple more cases of diverticulitis. Now we're on some exciting mimics. So epiploic appendigitis. Here we have that tourist epiploic appendage. We can even see that kind of central vessel and then that surrounding inflammation. So these you're going to carefully scroll up and down to see if there is potentially if that's just fat inflammation surrounding an inflamed diverticulum, but in the absence of any diverticula and seeing that convincing kind of like almost like small kind of oblong shape of the epiploic appendage, you can confidently make that diagnosis. And just another variety of that, but showing that elongated, tourist, and infarcted epiploic appendage with that surrounding inflammation. Omental infarct is another kind of variety of acute inflammation and ischemia of the fat to keep in mind. And sometimes it can be kind of subtle. So this patient had right abdominal pain, and you're going to more commonly find omental infarcts in the right abdomen. But notice how there's some fat, some inflammation centered on the fat in the right hemi-abdomen. I'll show that on coronal here, where it takes a little bit of shape. And you even see the vessel in it. So just kind of keep your eyes on that as I scroll through, and even that central vessel there. And just scrolling backwards a little bit. So you get the sense of that, the shape that the infarct has taken, the little bit of mass effect that it's having on the liver. And then this is accounting for right abdominal pain, omental infarct. And of course, we all want more omental infarcts. So let's take a look at another example. This one again follows a similar pattern though with that central vessel and then that inflammation centered on the fat. But again, it can be kind of subtle if you're not really looking for it. You might even potentially call it a colitis. Not that that would necessarily cause much harm, but just keep in mind that if it's the inflammation is centered on the fat and you're seeing some reactive changes to the colon, that you can start thinking about an omental infarct. And here's that last one. We even see that little bit of bright center to the vessel. And then as we're scrolling down, that inflammation. So hopefully getting a sense of that pattern that emerges with those omental infarcts. All of these examples that I found have been over the right abdomen. I have seen them in the lesser sac and some unusual places, but this is the most common location you'll find them in. All right, we're now getting on to some complicated versions of diverticulitis. This is a perforated diverticulitis of the sigmoid colon. And you're going to find a variety of appearances. So it just really depends, especially if you're dealing with immunocompromised patients, you might have a perforation that spreads and kind of goes way farther than you'd think. But in the patients who are not in an immunocompromised state or on chemotherapy, often the body's going to form this walled off response to that. So here's a patient with an abscess. Finding the perforated diverticula is often very difficult because the diverticulum you can imagine it gets obstructed and then it perforates, and then it's kind of like forming this thin channel that's communicating with the bowel, but otherwise is obscured by the surrounding inflammatory findings. So don't let the fact that you're maybe having trouble finding the culprit diverticulum throw you off. If you're seeing that this patient has a bunch of diverticula and then a characteristic appearance of perforation, you can make that diagnosis. We'll cover a couple more here. So as I mentioned, you have a variety of appearances here. There's a couple locules of air in the upper abdomen. Maybe you're seeing them there and scattered throughout. These can be relatively easy to overlook. And then we get down to the pelvis and then have this small collection along the upper margin of the sigmoid colon. Let me scroll back here. There it is. So yeah, again, there's a couple diverticula. One is larger than the other. And now in this case, we're not dealing with the leakage of a lot of enteric contents. We're largely just dealing with the leakage of air and some inflammation in the pelvis. So a little bit of a different variety in this case, but the air is tracking all the way into the upper abdomen. And of course, we have a third version. Let's see what this one shows us. So this is a different pattern that I think is really helpful to have your eyes trained on. And this is a pattern of peritonitis. So look at how thickened that small bowel is. That's just so impressive. There's a huge long segment of super inflamed small bowel. And maybe when you first scroll through this, your first thought is, okay, this is like a severe enteritis. But notice how it's really much of what's inflamed is actually the outer wall or the cirrhosis. So there's something contacting the small bowel that's causing such impressive inflammation. And this scrolling through the colon actually looks pretty good, right? It doesn't look particularly inflamed. There's a bunch of diverticula, but hang on a second. What is this thing? So let's look at another window here. Oh, actually, I had that coronal, but that's okay. We're going to look at the other window here. Okay. So there it is. That's extraluminal stool. That's bad. And so that's what's causing this robust and impressive picture of peritonitis. And so I just want to show that actually on the coronal because we really get a sense of that long segment of small bowel inflammation. Here we go. There it is, yeah. So super inflamed small bowel, peritonitis related to perforation of sigmoid diverticula resulting in extraluminal stool. All right, I think this is our last perforated case, I promise, but hopefully these are helpful to get a sense of the variety. They don't, similar to the appendix, they're not all just gonna do the same thing. So this is another kind of interesting one where when you get into the upper abdomen, there's not really free air. I don't think there's even many locules at all. When you scroll down, you see, oh, okay, there's a collection in the mesentery here. And then there's this really impressive inflammation of a segment of small bowel. Let's take a look at that on coronal. Yeah, so we see that inflamed small bowel loop, we see that inflammation in the mesentery, and then we see that small collection. So where is that coming from? So this is another pattern that I want you to be aware of, and this is the kind of sneaky perforated diverticulum here, where the enteric contents leaked up into the central mesentery, causing this abscess and causing this inflammation of the small bowel. But unless you're aware of that pattern, it could be really easy to overlook a perforation of this diverticulum as the culprit. When you're dealing with fistulizing cases of diverticulitis, there's often a characteristic appearance when you get into the pelvis. And honestly, if you had to maybe pick one word to describe that characteristic appearance, it kind of looks like a mess, right? So you scroll down, you're seeing complex, enhancing tethering between the loops of bowel. You're seeing these extraluminal tracts communicating within the different bowel loops, maybe pulling on the small bowel, or large bowel. So in this case, we actually have, if you follow the lumen here and back up, and then you notice above it is the fistulous tract, there's actually a colocolonic fistula. So this is like a complex, arborizing, inflammatory colocolonic fistula. So chronic fistulizing diverticulitis. This non-con CT is a little less inflammatory, than the last one, perhaps, overall, but shows more within the mesocolon, this complex, arborizing, fistulous mass causing multiple points of branching and communication within the sigmoid colon. So again, chronic fistulizing diverticulitis. And then as we scroll down a little bit, we can appreciate it's burrowing into the wall of the urinary bladder, causing urinary bladder thickening, but no intraluminal air. So starting to form an early fistula there. The different flavors of fistulizing diverticulitis can include a fistula of the ovary here. So here we have along the sigmoid colon, this kind of fistulous mass, this kind of complex arborizing web of inflammatory tracts, and eventually tracking into the left adnexa, causing this typical multiloculated abscess. The is this colovaginal or vesical? Colovesical, okay. So, this is colovaginal, okay. Colovaginal fistulas, this is not a very particularly common one, but the patient will present with a supporting history. There's a little bit of debris within the vaginal cuff here. The patient did have a history of hysterectomy, and then there's this kind of unusual track along the sigmoid colon if you follow that to the leftward vaginal cuff. So especially when you're dealing with more of a kind of a well-formed chronic fistula, you may not see as much robust inflammation, but you can keep that in mind as a potential appearance of a colovaginal fistula. You're also seeing some reactive inflammation along that fistulous tract of the bladder wall. Colovesical fistula here. So intraluminal air in the urinary bladder, we have to account for that. There's abnormal bladder wall thickening. And then scrolling up, there's actually just a thin tract there. I think I show it nicely on coronal here. Let's take a look. Go back. There it is. So the other point, we showed a lot of those diverticular cases where there's a huge inflammatory mess. But sometimes when you're dealing with a fistula tract, just keep in mind they can be relatively small and understated as well, just depending upon where you are in that setting of fistulous disease. But that thin channel of communication, even though relatively modest in appearance, is quite significant in resulting in that. So, all right, we can wrap up here with touching on a diverticular stricture. So a couple other complications. Here we have a large bowel obstruction, and resulting in this focal narrowing here was a chronic diverticular stricture. Usually you're not going to be seeing a lot of shouldering or abnormal kind of apple core appearance, but this is a diverticular stricture that actually formed this little bridging communication where there's a colocolonic fistula to bypass it. And the major thing to keep in mind for these patients, and I certainly wouldn't swing for the fences on this, a lot of these patients do require appropriate imaging follow-up, would be that of a obstructive sigmoid colon cancer. And I showed this case because there's not only a long segment of abnormal thickening and enhancement of the bowel wall without really a lot of diverticular disease to account for that, but there's also a fistula to the bladder. So just because you're seeing a fistula doesn't necessarily mean you should automatically assume that you're dealing with a diverticula-related fistula. So this patient not only had a colovesical fistula, but also had an upstream sigmoid carcinoma. So keep in mind the variety of appearances, including the presence of fistulas related to malignancy. And here's one more patient here at distal sigmoid colon with a malignant stricture, and then a couple of those mesocolonic lymph nodes that are just maybe a little bit too big to make us a little bit worried, although we could see those in the setting of diverticula. But the thickening of the wall, the absence of a lot of other diverticular disease raises concern for malignancy. And we'll just do this one last case here. This case is certainly a challenging one where it can be easy to overlook the primary tumor because there's so much bright, sparkly material within the colon, right? So this highlights a little bit of the importance of following a complete search pattern and eventually on coronal imaging, rewarding ourselves with finding that that relatively thin segment malignant stricture of the large bowel. So these can be easy to scroll through on axial, especially because you might think it's a focal contraction or a haustral fold of the colon, but looking at it on coronal and sagittal will help you to find the tumor. One last variety that you might see as a complication later is the presence of liver abscesses, where there's often a thick rind. You might see more of a complex septated collection. And then this patient was complicated by thrombosis of the middle hepatic vein. And this is often, when this is related to diverticular disease, I usually don't see the patient presenting acutely with diverticulitis, but rather as more of a delayed complication. And there's our drainage images here. All right, I do apologize, I'm going over just a minute here, but I'll just touch on this last case. So acute diverticular bleed, the patient inappropriately got oral contrast for this, but fortunately, we can see the 2 stages here of a late arterial, or actually kind of more of an early arterial and then a portal venous phase. And we're seeing that little jet of contrast shoot out from the diverticulum and then disperse on portal venous phase for an acute diverticular bleed. Okay, so we covered the spectrum of diverticulitis, including duodenal, small bowel, appendiceal, and colonic. We covered some important complications, including perforation, abscess, chronic, and fistulizing diverticulitis. And we touched on the mimics, appendigitis, a mental infarct, foreign body, and neoplasm. So thank you again very much.